An infected female Anopheles mosquito lands on human skin. She pierces the dermis to extract the blood she requires to produce eggs, and in the process, she injects saliva containing an anticoagulant and microscopic Plasmodium parasites directly into the human host. This is Juan, a 48-year-old botanist who recently returned to the United States from a 3-week trip to the Brazilian Amazon. He did not seek pre-travel medical counseling, relying solely on intermittent mosquito repellent. This graph plots his clinical presentation. Exactly 14 days after returning home, he develops a sudden onset high fever of 103.5 degrees, accompanied by severe shaking chills. As the timeline shows, these intense paroxysms occur periodically, striking exactly every 48 hours. A fever in a returning traveler must be treated as malaria until proven otherwise. Looking at this 2023-2024 regional map, Brazil accounts for roughly 1/3 of the malaria burden in South America, with transmission concentrated in the Amazon. Notably, 82.5% of these cases are driven by a single species, Plasmodium vivax. Prioritizing a meticulous travel history is the critical first step in narrowing the diagnostic field. Knowing precisely where a patient has been provides the epidemiological context needed to avoid a fatal misdiagnosis. Juan's routine laboratory tests reveal mild anemia and mild thrombocytopenia, indicators of red blood cell destruction. This triggers an immediate rapid diagnostic test. This schematic demonstrates the logic of a dual antigen RDT. In Juan's case, the results are discordant. The cassette is positive for aldolase, but negative for HRP2. The positive aldolase line is a pan-Milan marker. It confirms that a Plasmodium species is present in the bloodstream. The negative HRP2 line is the critical piece of the puzzle. Because histidine-rich protein 2 is specific to falciparum, this result effectively rules out the most dangerous and deadly form of the disease. To confirm the species, we use light microscopy. This illustration compares a normal red blood cell on the left with the infected cell on the right. Plasmodium vivax preferentially targets young, pliable reticulocytes, resulting in these visibly enlarged host cells. Inside the cell, the parasite presents as an irregular, spreading amoeboid trophozoite. Throughout the cytoplasm, we identify Schaffner stippling, fine punctate granules characteristic of the species. Because it only invades young reticulocytes, parasitemia typically hits an upper limit of 1.5%. The combination of the discordant antigen results and these specific cellular features definitively confirms Plasmodium vivax. However, eradicating it requires a specialized two-pronged therapeutic strategy. This diagram illustrates why P. vivax is so difficult to eliminate. It occupies two distinct anatomical zones. On the right, the erythrocytic stage drives Juan's acute cyclical fevers. But on the left, dormant liver hypnozoites remain quiescent, posing a hidden threat for future relapses. To achieve a true radical cure, we must target both compartments. This requires a blood schizonticide to clear the active infection and a tissue schizonticide to eradicate the dormant liver stage. If we only treat the bloodstream, the dormant hypnozoites will eventually reactivate, guaranteeing a clinical relapse. Because the strains in Juan's region remain largely sensitive, the standard 3-day treatment for the acute phase is chloroquine. Chloroquine kills via vacuolar autointoxication. Trapped inside the parasite's acidic food vacuole, it binds directly to free heme, a toxic byproduct of hemoglobin digestion. This prevents biocrystallization into safe hemozoin, causing a lethal buildup that poisons the parasite from the inside out. While the standard 3-day course is highly effective, it can cause gastrointestinal distress, headaches, and severe itching, especially in patients of African descent. Chloroquine's antipyretic properties will rapidly resolve Juan's fever within 72 hours, but because the drug cannot reach the liver, he is not yet cured. To prevent relapse, we must introduce primaquine, the only drug class capable of eradicating the dormant liver hypnozoites. Primaquine is a prodrug. It relies on the host's liver enzyme, CYP2D6, to metabolize it into highly reactive oxidative intermediates. These metabolites target the hypnozoites directly, destroying their mitochondrial electron transport and killing the latent parasites. Because this depends on host metabolism, patients with specific genetic variations in their CYP2D6 enzyme are at a significantly higher risk of treatment failure. However, these oxidative metabolites can also attack human red blood cells. In healthy individuals, the G6PD enzyme protects the cell by maintaining glutathione levels to neutralize stress. But in G6PD deficiency, these metabolites destroy the red blood cell membrane, causing life-threatening hemolytic anemia. Because of this risk, quantitative G6PD testing is strictly mandatory before any Primaquine prescription. Juan's results show normal activity at 70% or higher, clearing him for radical cure therapy. Following the 3-day chloroquine regimen and a full 14-day course of Primaquine, Juan's blood parasitemia clears and his dormant liver stages are eradicated. This table compares the two-drug framework. Chloroquine clears the blood parasites over 3 days, while Primaquine eliminates the liver stage over 14 days, provided the patient passes the mandatory G6PD toxicity check. For medical students, the core principles are clear. Take a meticulous history, recognize RDT discordance, treat both anatomical compartments, and never skip the G6PD test. Prompt diagnosis, dual compartment treatment, and proper safety screening ensure a full recovery with no future relapses for the patient.